Hello, I'm Dr. Nicholas Tedesco D.O, Co-Associate Program Director for Good Samaritan Regional Medical Center's Orthopedic Surgery Residency Program. Today I'll be lecturing on benign soft tissue tumors and tumor-like conditions in accordance with our online lecture series to augment our case-based presentations in the classroom. I do have a disclosure to make, and all of my disclosures are up to date on the AAOS website and searchable by my name. We'll begin the benign soft tissue lecture with lipomas versus atypical lipomatous tumors. The other name for atypical lipomatous tumor used to be low-grade liposarcoma, but this has been reclassified by the World Health Organization because an ALT has no ability to metastasize in and of itself. However, it does have an ability to de-differentiate into a high-grade sarcoma, whereas lipomas do not. A lipoma is a mature, benign fatty tumor. Usually we leave them alone unless they're growing or symptomatic from mass effect. Derkham's disease is multiple painful lipomatosis, usually in the upper extremities, and it's 20 times more common in postmenopausal females than other patient populations. Atypical lipomatous tumor, however, can be found in almost any age group, but typically middle age as well. Characteristic MRI findings are often what are described as, quote, dirty fat, with stranded fat and a more lobular and infiltrative appearance in the intermuscular planes as opposed to a standard large lipoma. However, several studies have now demonstrated that there is no reliable features of either a lipoma or atypical lipomatous tumor on MRI that are pathognomonic, and therefore a diagnosis cannot differentiate between the two of these based on imaging alone. The ALTs, because they can de-differentiate and degenerate into a high-grade malignancy, must be excised, whereas lipomas often are just simply observed. And the risk of de-differentiation is only about 2% with atypical lipomatous tumors. So here's MRI imaging of an example of both. So the image on the left there is a large intramuscular lipoma in the trapezius muscle up near the neck, and you can see that it is predominantly mature fat with only a small amount of stranding in it that are either residual muscle fibers or blood vessels usually. Then you see on the right side that characteristic quote-unquote dirty fat, or the more infiltrative growth pattern into the muscle, especially on the deep surface there, and this particular tumor was an atypical lipomatous tumor. However, again, these are not reliable features, and without a true tissue diagnosis, an atypical lipomatous tumor could look just like the image on the left and a lipoma on the right. So tissue sampling is needed to get the definitive diagnosis. So on histology, a lipoma is nothing but mature fatty tissue. It's usually MDM2 and P16 negative. And another characteristic feature is that these are virtually non-existent in the retroperitoneum. Usually a large fatty mass in the retroperitoneum is an atypical lipomatous tumor until proven otherwise. The differentiation here is that histologically there's usually atypical lipoid cells within a large amount of fibrous septae between the lobules of normal fat seen on an atypical lipomatous tumor. Additionally, it has a very characteristic and pathognomonic ring chromosome 12 with amplification of the MDM2 and CDK4 gene, which is usually the diagnostic test of choice to differentiate these two. So here are electronic micrograph images of those two disease pathologies. The one on the left is a mature lipoma. So again, you see nothing but wall-to-wall fat, only a small amount of septations and stranding within it, but otherwise mature fatty cells. However, on the right, you see a lot of mature fat cells, but you do see some immature ones, especially scattered within this densely fibrous septae running between all of these lobules. So on the high-powered view up above, what you see as you zoom in is that it's mostly fibrous tissue, all of that pink background with only a small amount of fibroblasts present, which are the nuclei there. However, it's not pleomorphic, it's not hypercellular, or anything like that that would otherwise give away a frank malignancy. Now we'll move on to Hibernoma, which is another fatty tumor. It is a rare yellow-brown fat tumor, typically found in older adults and males most commonly. Usually it's found in the posterior neck, or what's called the buffalo hump on the back of the upper part of the thoracic spine, or the cervicothoracic junction. And the axilla is the next most common place to find these. On imaging, it will usually be a well-defined soft tissue mass, but heterogeneous, with regions of hypointensity to fat and skeletal muscle on T1 and hyperintensity on T2, but there still will be preservation of at least some fat signal interspersed throughout the lesion on both the T1 and T2 imaging. Here's an example of one overlying the shoulder, where on the T1 imaging in the upper left, you see a predominantly fatty, well-circumscribed mass. However, there is a large amount of heterogeneity within it and that dark signal present, especially centrally. Then when you flip to the fat-saturated T2 imaging on the right there, you can see, again, the fat does saturate. That confirms that it's fat, but you see those septations and heterogeneity in the middle being hyper intense, indicative of additional tissue that's not specifically fat. And then the post-contrast sagittal imaging down below shows that similar regions to the hyper-intense portions on the T2 enhance with contrast, but the majority of the fatty tissue does not. On histology, you'll see normal fat intermixed with vacuolated, bubbly, eosinophilic brown fat, which is the characteristic appearance due to increased mitochondria, and numerous blood vessels will be present throughout this lesion. It'll be oil red O positive because of the lipid component, S100 positive, and there may be chromosome 11 abnormalities. Treatment, cut that thing out because they do tend to grow over time and tend to be symptomatic or have mass effect eventually. So here's a low power example of that histology where you see some large mature adipocytes, but running between that you see all these eosinophilic cells, and then again some fiber septae running between these lobules. As we zoom in, here's where you see that bubbly eosinophilic cytoplasm as a result of all that extra mitochondria. But when you stain this, instead of those clear areas being glycogen like you would see in a PAS stain, instead an oil red O stain will be positive for lipid in those clear areas that confirm the fatty origin of these cells. A lipoblastoma is sort of the lipoma counterpart in a child. So it's a benign fatty lesion, but often confused with liposarcoma, especially histologically because of the presence of lipoblasts and various stages of maturity of the fat cells. However, on imaging, it typically is more like a lipoma rather than a liposarcoma. So there may be some heterogeneity in it, but often largely homogeneous, with fatty signal on all sequences. Because of the slight heterogeneity, it can look like an atypical lipomatous tumor or a well-differentiated liposarcoma, so histology is key here. Here's an example of that. This was a 10-year-old child with a large mass in the posterior thigh, and you can see the T1 imaging on the left, almost all fat signal with only a small amount of heterogeneity. T2 with fat saturation on the right there, it completely saturates, and then down below is the post-contrast imaging where the lesion doesn't really take up any contrast at all, consistent with a very benign process. On histology, you'll see lobulated tissue composed of lipoblasts in different stages of differentiation, ranging from primitive spindle-shaped lipoblasts to mature, large adipocytes and fat cells. But typically these areas are separated by a fibrovascular septa and areas of myxoid matrix. Treatment is very similar to a lipoma, which is either observation if it's not growing, small, or asymptomatic, versus a marginal excision if it's bothersome or large. Here's an example of that histology where again you see these lipoblasts ranging from spindle cells all the way up to mature adipocytes that can look very similar to a liposarcoma in an adult. However, liposarcoma is very, very rare in children. The other big thing here is when you look closely, all of the nuclei that are present appear relatively homogeneous. There's not a whole lot of pycnosis, there's not a whole lot of mitotic figures, and certainly no atypical mitotic figures, so really benign features of progressively maturing fat cells. Synovial arborescens is an intra-articular soft tissue mass. It's a frond-like intra-articular fatty proliferation and most commonly seen in the knee, and if so, usually either in the gutters or the suprapatellar pouch. On imaging, an MRI will be the test of choice. Usually it's not visible at all on an X-ray, but it will show a villous and frond-like overgrowth of the synovium and adjacent fatty tissue in combination with synovitis. And because of the way the MRI makes its slices, often these villi are cut off, and so they look like a large amount of multiple loose bodies, and so this can be misdiagnosed very easily on an MRI. On histology, it's a synovial-lined villous proliferation that's diffusely infiltrated by mature fat. Treatment is open or arthroscopic resection, with or without correction of the underlying joint disease, because this is often seen in middle to overage adults with significant intra-articular pathology like end-stage arthritis or something like that. So you may be able to just simply remove this at the time of a total joint replacement. Here is that MRI with a T1 on the left and T2 on the right. This gives you a good example there, how you have that appearance of multiple intra-articular loose bodies, especially on the right side there with the large joint diffusion and all of those dark regions that don't seem to obviously be connecting to the synovium. But you can also see the significant arthrosis with full thickness cartilage loss and large osteophyte formation. The other thing you see on the left on the T1 is that there's fat signal intensity within those lobules. So again, it suggests that this is a fatty proliferation, not loose bodies, which are usually going to be cartilage or calcified cartilage. And so this can help make that diagnosis radiographically. Here is that histology where again you see the synovial lining, which is that thin layer of hyperdense cells on the surface of this villus proliferation. But then within this villi, you see all of those fat cells interspersed with all of the collagen and vascular structures on the background. So it suggests that it's a benign process, predominantly fatty infiltration, villus-like proliferation of the synovium. Tenosynovial giant cell tumor is categorized as either diffuse or localized. Diffuse is a process that involves the entire synovium, and localized is usually a nodular or focal mass of tenosynovial giant cell tumor. This used to be called pigmented villonodular synovitis, but the World Health Organization has reclassified that because histologically and by natural history as well as genetically, this is identical to the tenosynovial giant cell tumors of tendon sheath that used to be seen in the wrist and hand that we thought were a separate tumor from PVNS. However, it turns out they are the exact same and just variations of presentation of the disease. On presentation, this is usually painful and accompanied by swelling, possibly recurrent bloody effusions, erythema, decreased range of motion, and may even have mechanical symptoms if there's a large mass effect within the joint. It's typically a disease of younger to middle-aged adults, and on imaging, you may see well-defined erosions without significant osteophytes on both sides of the joint on X-ray, and so the differential diagnosis usually includes gout, rheumatoid arthritis, or infection or other processes that get multiple regions of a joint, as opposed to a tumor that usually is only on one side of a joint. But really, the diagnostic test of choice is going to be MRI. And MRI will show low signal intensity from the hemosiderin deposition on all sequences. It could be nodular, especially in the localized form where you have one large mass of it. And usually there will be some reactive edema on the MRI, but when you look at how dark the synovium is from all of that hemosiderin deposition, it really differentiates it from things like infection and gout, where usually the synovium is nothing but bright signal on T2 because of that reactive process only without the hemosiderin deposition. So here's an X-ray that does demonstrate the erosions in the distal tibia, the distal fibula, and the talus. You can see that they're very sharply defined with a narrow zone of transition and even a sharp sclerotic border around portions of them. But because it involves multiple bones, that usually leads us towards this as well as the other differential diagnosis we just listed, as opposed to a polyfocal bone tumor. And then MRI is going to be your diagnostic test of choice with T1 on the left and T2 on the right there, where again you see the jet black hemosiderin deposition throughout those nodules within the bone, throughout the joints, and even outpouching into the submalleolar area of the lateral malleolus. On the T2 imaging on the right, you can see all of that surrounding subcutaneous edema indicative of the reactive process, but you still see the very dark areas of the synovium that is not characteristic for infection or inflammatory arthritis. Here's the post-contrast imaging where, again, the hemosiderin deposition does not uptake any of the contrast, but all of the inflammatory change around it does. So you can see the inflammation enhances, but there's no real enhancement of any mass-like process that would otherwise suggest maybe a hemorrhagic sarcoma or something like that. Histology of tenosynovial giant cell tumor usually shows the diagnostic brown hemosiderin-laden mononuclear stromal cell infiltrate with villus synovial proliferation. There is a characteristic translocation 1-2 involving the colony-stimulating factor 1 and collagen 6A3 fusion in the tumor cells. This recruits a large amount of monocytes expressing the CSF1 receptor, which is a tyrosine kinase. The discovery of this has opened up the door for targeted chemotherapy agents against this receptor. This will usually be a CD68 positive tumor because of its histiocytic lineage, and treatment is either arthroscopic or open removal of the tissue plus or minus radiation, depending on the degree of disease or how many recurrences they've had. There is a high recurrence rate of this, especially in diffuse subtype as opposed to localized, which indicates a complete synovectomy is required for that disease as opposed to just visual areas of the disease. There's now a new anti-CSF1R tyrosine kinase inhibitor called pexidartinib that has been FDA approved for this disease. As a result, it's changing how we manage diffuse type, especially in the recurrent setting or the unresectable setting. Here's a low power image of that histology that shows those brown hemosiderin-laden macrophages scattered throughout the synovium and subsynovium. As we zoom in, you see the giant cells that are scattered throughout here, as well as the mononuclear cells in the background, but you can see that the giant cell nuclei as well as the background nuclei are all almost identical, and again, no real pleomorphism here or mitotic figures or anything that would suggest a malignant process. Here are arthroscopic pictures of what the disease looks like, where you have this villous proliferation jutting out into the joint from the synovium. It's very hyperemic from all of the increased blood flow as well as the hemorrhage leading to that hemosiderin deposition. And so you can see just how diffuse it infiltrates and involves almost the entire synovium. That does require resection of all of this at the time of surgery. A Schwannoma is also known as a neurolemoma, which is a benign soft tissue mass involving nerve sheaths. It tends to involve nerve roots at a greater rate than peripheral nerves, and it is associated with nerves, but it's not intraneural. So it is confined within the perineurium, but it pushes the nerve fascicles to the perimeter and doesn't actually involve them. On presentation, most of these patients will have pain, especially with a positive Tenel sign, and they'll have a firm to rubbery mass in the area in question. On imaging, MRI will show a heterogeneous mass with predominantly low signal intensity on T1, bright signal on T2 because of the myxoid component, with tapered ends on the longitudinal cuts. So on the coronal and sagittal, it'll be more oval in shape with tapered ends at the top and bottom, but it will be usually almost close to circular on the axial cut, so almost football shape. A target sign is very characteristic for nerve sheath tumors, including both this as well as a neurofibroma, which is a post-gadolinium image that shows a hyperintense periphery of the uptake from the gadolinium with a mixed center, where the nerve fascicles actually are that are not uptaking the contrast dye. A string sign is usually on the longitudinal cuts like an AP or a sagittal, where you see the nerve actually going into and coming out of the lesion on those cuts. So here's an example of one of these in the axilla involving portions of the brachial plexus coming into the arm. On the T1 image on the upper left there, you can see a large discrete round ball on the axial cuts. On the right side, you can see the T2 imaging showing a heterogeneous lesion but very bright signal, again because of the myxoid component that holds on to water. And then down below, you have the post-contrast imaging with that target sign, where you have that central region with no contrast dye uptake, but the peripheral portion that does. This is the same lesion on the coronal cut. On the longitudinal, you can see that string sign where the nerve itself is actually coming out of the lesion. That you can see even better on the inferior aspect of this as opposed to the superior, but you get a sense that the nerve is going into it superiorly there as well. And again, you can see more of the tapered ends as opposed to the purely circle-shaped lesion on these longitudinal cuts. Histology will show spindle cells in intersecting bundles. This is the so-called Antony A region of these, as these are a biphasic tumor involving two populations of cells. And so this Antony A region will be superimposed on a hypocellular, loosely arranged collagen myxoid background, which is called the Antony B region. I remember these as Antony B being the background. So the predominant tissue type, which is the myxoid stuff, but then the Antony A region coming in on top of that. Treatment for these is usually marginal excision with care not to damage the involved nerve versus observation if it's involving a large major nerve or asymptomatic. You do need to enter the perineurium with a longitudinal split, but then try and do blunt dissection. However, there's almost always at least some degree of iatrogenic nerve damage here. So counseling the patients is very important prior to undertaking surgery for these. So here's a low power micrograph where you get the sense of that loosely arranged myxoid background tissue, which is all the lighter and white stuff. The white areas are being taken up by fluid, which is why it's so bright on the T2 imaging. But then you see that multiple fascicles of darker cells, which are the Antony A regions, scattered throughout this. As we zoom in here, here's that myxoid collagen background, but then you can see the dark black arrow there at the top pointing to the Antony A region, which is those palisading and intersecting bundles of spindle cells. Neurofibromas is the next soft tissue tumor that we'll talk about. These are very common and multiple with von Recklinghausen's disease, which is neurofibromatosis type 1. This is an autosomal dominant chromosome 17 defect in neurofibromin. It usually inhibits the RAS proto-oncogene, which is why they form all of these tumors. As a result, they tend to have greater than 6 cafe au lait spots with the, quote, coast of California or smooth borders, as opposed to the coast of Maine cafe au lait spots, which are roughened borders seen in McCune-Albright syndrome. They will have multiple cutaneous and deep neurofibromas, optic gliomas, and very commonly will develop a malignancy at some point in their life, usually in the CNS. The plexiform type is a solitary, large, deeper one that usually involves multiple branches of major vessels, named for its growth pattern. Malignant transformation in neurofibromatosis is anywhere from 2 to 30% and worse with the plexiform type of mass as opposed to a solitary, smaller neurofibroma. Therefore, long-term follow-up is often needed with these patients to monitor for any potential for malignant change in any of their known sites of disease, particularly the deeper, larger ones that involve multiple branches of different nerves. Some recommend yearly whole-body PET scans because it can delineate the extent of the disease as well as differentiate benign from malignant lesions based on the degree of the SUV. Here's an example of a patient obviously very heavily involved with this with multiple cutaneous neurofibromas. On imaging, the larger, deeper ones will be very heterogeneous on MRI with predominantly low signal intensity on T1, bright on T2, and again, just like the neurolymphoma, will show the relationship to the nerve with a string sign on the longitudinal cuts. And these will enhance with gadolinium as well, and they are also very common to have a target sign similar to the Schwannomas. Histology demonstrates interlacing bundles of bland spindle cells with mucoid stroma. They are S100 positive because of their neural lineage, and treatment is somewhat difficult. Usually observation is what we elect to do here because excision is difficult, especially in the plexiform subtype where they're relatively infiltrative. And so usually you have to sacrifice and remove the entire involved segment of the nerve in order to remove these safely. In some of the neurofibroma kids, with this being so large, often it has already destroyed the nerve or killed it, where there isn't any function left in the nerve, so removal isn't as morbid as you would think. But it does bear a conversation with the patient that some of their neurologic symptoms may change and may be permanent once excision is undertaken. Here's an example of one of those very large ones involving the sciatic nerve. On the left side there, that's the T1 imaging, where it's slightly heterogeneous, but predominantly low signal intensity to maybe isointense to skeletal muscle. On the T2 there in the middle, you can see it's very bright because of that mucoid stroma, again holding on to a lot of fluid. And then the post-gadolinium image on the right there, that shows that target sign in the middle. That is indicative of a neurogenic tumor. Here's the longitudinal cut of it, where again it's circular on the axial cuts, but very elongated and ovoid on the longer cuts. Here is a whole body PET CT of a patient with neurofibromatosis with the arrows pointing to the larger sites of her disease where we are monitoring for malignant change. And again, you get a sense of just how dark that one in her neck is. That is consistent with probable malignant change compared to some of these other ones in the periphery. A glomus tumor is a benign neoplasm arising from the glomus body, which is a dermal arteriovenous shunt surrounded by a capsule of connective tissue that's involved with temperature regulation. And so therefore the highest concentrations of these are found in the fingers and toes, which is why these are the most common areas to get these, especially in the nail beds. On presentation, these are almost always very painful and worse with cold exposure. Discoloration can be present ranging from white to blue, and they may even elevate the nail bed or disrupt nail matrix formation. They are usually solitary, but some patients can develop multiple glomus tumors. They can actually occur anywhere on the body as well, but classically the hands and toes are what we think of. On imaging, these will be a dark, well-defined mass on T1, bright on T2, with bright intralesional contrast enhancement post-gadolinium. Here's an example of a large one around a patient's knee, where you can see it's almost the size of his patella. Here's where you can see it even emanating and growing away from the skin, creating that large mass that's visible, and again demonstrating its size in relation to the adjacent patella. On the upper left there, that's the T1 image with a relatively homogeneous but slight heterogeneous lesion with low signal intensity, very bright on the T2 on the right, with bright intralesional contrast enhancement down below. Histology will show a well-circumscribed perivascular hypercellular mass composed of multiple vascular channels and monotonous cuboidal cells. So it's scattered S100 positive in the background stroma. Variable cells will be positive for substance P, but strongly COX-2 positive, which is one of the reasons it hurts so bad on immunohistochemical staining. Reticulin, laminin, and collagen type 4 are also positive, but not specific to this disease. Treatment is usually NSAIDs to control the symptoms versus surgical resection if it's in a tough spot or very symptomatic for the patient. Here is that histology where again you see these bland monotonous cuboidal cells surrounding these large vascular channels. This will be in direct contrast to hemangiomas that we'll see presently that are more spindle cell endothelial tissues, but otherwise remarkably similar. So the cuboidal nature of this is what gives it away without any knowledge of the IHC staining. But again, if they show something like this and say strongly COX-2 positive, it's a glomus tumor. So now we'll jump to those hemangiomas. This is not a true tumor, but rather a tumor-like condition because it's more of a hamartomatous proliferation of otherwise normal vascular tissue. These can cause aching pain, worse with exercise or dependency as the vessels become engorged, and they may change in size or increase heat production during these events as well. They can also undergo cyclic thrombosis from the tortuous nature of the blood vessels that lead to eddy currents and stasis. And so you can have a relatively asymptomatic lesion that every couple months or a couple of years becomes very inflamed and painful and then resolves again as that clot clears. On imaging, especially for intraosseous hemangiomas, you will see bony lysis with thick vertical trabecular striations, often referred to as jail bars, especially in the spine. Soft tissue hemangiomas may show phleboliths on the X-ray, and on MRI, these lesions will be heterogeneous in nature, but they'll show a serpentine pattern of blood vessels with fatty or fibrous regions interspersed between the blood vessels and significant intralesional gadolinium uptake within the blood vessel itself. So again, in that same tortuous and serpentine pattern. Here's a large intraosseous one seen on the X-ray on the right where it almost looks like the sunburst of a potential osteosarcoma, so they can look relatively aggressive. However, when you get the CT scan, you see those dense bars of trabeculation with bony lysis in between and no real periosteal reaction or soft tissue mass extension. Here's an example of the soft tissue phlebolith seen in a very large calf intramuscular hemangioma. And then here's an MRI of that same calf intramuscular hemangioma where you see this low signal intensity region on the left with interspersed fat throughout it. But then on the right, you really get the sense of that serpentine pattern of blood vessels going throughout this thing. On histology, very similar to glomus tumors, it will be numerous vascular channels with a bland fibrous stroma in between, but the cells will be usually more spindle shape as opposed to cuboidal. They will also stain positive for endothelial markers such as CD31 and 34, but negative for COX-2 or substance P. Treatment is usually activity modification with or without compression stockings, maybe serial MRIs to confirm the diagnosis and make sure it's not changing. Otherwise, you can attempt percutaneous sclerosing agents or embolization through interventional radiology if they're very symptomatic, and then resection with a wide margin of normal tissue if all else fails. And the reason you do that is because there's a high risk of recurrence with these if you leave too much behind. So here are those vascular channels being lined by the more spindle-shaped cells with the fibrous septae running in between the vascular channels where you see that wavy pink cartilage being formed there. You don't see any mitoses or hypercellularity within that background. And again, when we contrast this back to the image of the glomus tumor, you can see a much more cuboidal cellular morphology morphology surrounding these vascular channels. Tumoral calcinosis is another tumor-like condition, which is usually a periarticular reactive fluid or paste-like soft tissue calcium deposition, but they will eventually solidify if left long enough. They are outside the adjacent joint capsule, usually not involved directly with the joint, and they're not a true neoplasm per se of autonomous cellular growth. They're usually seen in patients undergoing renal dialysis due to hyperparathyroidism-related hypercalcemia from decreased vitamin D as a result of the renal failure. Serum calcium can be normal, but phosphate and PTH are often significantly elevated. Likewise, patients with issues with phosphate metabolism, they can develop this disease as well. Other names for this is calcinosis cutis, especially when you're talking about like Crest syndrome and calcium deposition in the fingertips, or calciphylaxis is the other name for this, which is essentially autonomous calcium deposition in the soft tissues because of an overabundance of calcium and or phosphorus. Imaging will show extensive, fluffy, but otherwise dense soft tissue periarticular mineralization on X-ray and CT. MRI will often show a multiloculated calcific fluid collection with very low signal intensity on all the sequences, similar to bone cortex. There may be surrounding edema on T2 and peripheral enhancement of that region post-contrast if it's irritating tissues enough or symptomatic. Here's an example around the elbow where you see that fluffy or cloud-like but otherwise dense calcification, very mature in production, and you don't have that zonal phenomenon like heterotopic ossification where you have a peripheral, almost neocortex with central portion less mature or less densely calcified. This is pretty diffusely calcified throughout. On CT scan, again, you see it involving the soft tissues dorsal to this patient's spine with dense calcium deposition. You can also see air in this because this actually approached and fungated through the skin, which led to infection. Here's an axial cut of that same CT showing this dense calcium deposition in the soft tissues overlying the spine. And then this is that same elbow lesion now on the MRI that shows on the T1 on the upper left a near jet black signal to these lobulations of the calcium deposition, similar to the bony cortex. Same thing on the T2, but now you do see that bright signal at the periphery of this that all enhances down below post-gadolinium, consistent with inflammation and reactive process. Histology will show densely loculated masses of calcific debris and fluid enclosed by very hypocellular fibrous tissue, which is often the reactive tissue, and scar tissue being left behind by the damage that this is causing. Treatment is going to be normalization of serum phosphate levels with or without wide resection of the lesion if symptomatic or large enough. Recurrence is almost inevitable if any is left behind or if the underlying cause is not addressed. So if the phosphorus continues to remain high, they're going to either develop another one or new ones throughout the body. So here you can see almost nothing but protein deposition without a whole lot of cells in that pink milieu surrounding these large regions that are predominantly white because they're fluid filled, but the dense dark purple calcific debris that's scattered throughout that fluid. Here's another example where you have a more reactive process where you have this huge inflammatory infiltrate, including lymphocytes, which are all those darker small cells, infiltrating around this large focus of calcific debris within an otherwise fibrous stroma around it. So that brings us to the end of our discussion about soft tissue tumors that were not addressed elsewhere in the other lectures. So I'll leave you again with my Pacific Northwest Pride slide. This is Mount Rainier, taken from Mount Rainier National Park. It's about a 4-hour drive from Corvallis and about a 1-hour drive from Seattle, and an amazing place to visit if you ever get the chance. Thanks for listening.